Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on prostate cancer expert consensus meet. And with immense pleasure, I would like to welcome and invite Dr. Major General B.N. Kapur, who is Director, Department of Medical Oncology, Yashoda Super Specialty Hospital, Ghaziabad, for his welcome and introductory note and to set the ball rolling. Over to you, sir.
Yeah, thank you very much. Thanks a lot. And at the onset, I must thank the organizer to giving me the opportunity to be a part of this Allied conference. And it's a great pleasure to see a lot of good speakers, a part of the CME. And I welcome all of them and to have a very interactive session among us. Today we will be discussing on prostate cancer, and prostate cancer is one of the very common cancer which is there. There are about 1.4 million cases world over every year, and more than 3 lakh patients do die of prostate cancer. And it is in the world over, it is the second most commonest cancer and the fifth most common cause of death is with prostate cancer. And there are a lot of newer things which are coming up in the management of the prostate cancer. Initially it was in the localized carcinoma prostate, the treatment by surgery, by radiotherapy, then androgenic deprivation therapy, and a lot of genetic testing, which are newer things in prostate cancer. To discuss all of these things, we are here today evening, and I do welcome Dr. Colonel Amit Shah, who is the HOD Urology at Army Hospital RNR, to chair the session and to continue the next talk. Dr. Amit Shah, please. Amit, you are not audible, please.
You have to remove your headphones. You are not audible.
Yes, sir. I agree to the points brought out by sir that it's a cancer which is growing. The diagnostic modalities have increased and it has led to better detection and early detection of this thing. However, still in our scenario, we are getting locally advanced cancers in a large proportion as compared to the West. So here we have Rajesh Nayak, who will give us the recent updates on the management of locally advanced prostate cancer. Rajesh Nayak is working presently as a medical oncologist at Command Hospital, Lucknow. He recently left us from RNR and has joined there a year back. I welcome Rajesh Nayak for his talk.
Thank you so much, sir. Am I audible, sir?
Yeah, you are audible, Rajesh.
Very good evening to all. In next 20 minutes, I'll be discussing about management of locally advanced prostate cancer and recent updates. I'll share the slides. Sorry, I'm not able to share the slide. Can you please share it for me? Hello?
Yeah, Aru, do we have Amit's slide? Yeah, here it is, sir. This is Rajesh now.
Yeah. Thank you. Next slide. As per Globocan 2020, prostate cancer constitutes 7.3% of all new cases and 3.8% of all new deaths globally. It is predominantly a disease of elderly, and maintenance of castrate level of testosterone is the foundation approach for all prostate cancer disease state, where it be localized disease or a non-metastatic CRPC, or a metastatic prostate cancer, which can be hormone sensitive, or a castration resistant prostate cancer. Next slide. So careful risk stratification is very much essential for management of prostate cancer. This helps in appropriate selection of therapy for consideration of, just this slide is only partially visible. Or for this helps in the careful selection of therapy and for better pre-treatment counseling of the patient and for selection of patient for clinical trials. Various parameters used in the risk stratification are serum PSA, Gleason score, and T staging. When it is used in combination, it is better than using it as alone. Next slide. So generally for risk stratification, we have a low risk, intermediate risk, and high risk patient based on PSA level, Gleason score, and the T staging. Next slide. So we have various risk group stratification as per NCCN, ESMO, and EAU guidelines. So these risk stratification model, these risk groups are quite heterogeneous groups. So like NCCN, they have divided low risk into very low risk, high risk into very high risk, and intermediate into favorable and unfavorable intermediate risk group. High risk group itself is a heterogeneous group. We have on one side high risk patient who behaves better with multimodal treatment, and on other side high risk group patients with very high risk of progression, metastasis, and biochemical relapse. Next slide. So there is no definite consensus regarding the definition of locally advanced prostate cancer. So we define locally advanced prostate cancer as prostate cancer more than T3 or more, that is cancer with extracapsular extension, cancer invading the seminal vesicles, or cancer invading the adjacent organ with nodal or with the nodal involvement, irrespective of PSA level and Gleason score. Next slide. In the diagnosis for detection, characterization, and local staging of prostate cancer, there is a definite role of multi-parameter MRI. It enables reliable detection of clinically significant prostate cancer, and it is currently the leading imaging modality. Next slide. So for the treatment of locally advanced cancer, it's basically a multimodal treatment where we have radical prostatectomy, neoadjuvant androgen deprivation therapy, radiotherapy, adjuvant ADT, and the emerging role of adjuvant chemotherapy also. Next slide. So the present guidelines says there are 3 modalities which are used in the management of locally advanced prostate cancer. The available options are EBRT plus brachytherapy boost, or EBRT alone, both in conjunction with the long-term androgen deprivation therapy, and in carefully selected patient, radical prostatectomy with the extended pelvic lymph node dissection with post-operative adjuvant RT and androgen deprivation therapy. Next slide. Radical prostatectomy, we have many retrospective cohort studies where radical prostatectomy is used as a part of multimodal treatment. It has shown that there is a definitive improvement in the 10-year cancer-specific survival of around 87%, 15 years cancer-specific survival of around 60%, and 10-year OS of around 75%. Next slide. So in carefully selected patients, that is in young patients with no too much fixity of prostate to the surrounding tissue, and especially in patients with non-cancer lower urinary tract obstruction, which is not responding to medical therapy, radical prostatectomy is one of the option. Next slide. Role of EBRT or alone or EBRT with the ADT is also there in management of locally advanced prostate cancer, and ADT in combination with LHRH analog plus anti-androgens is used as initial or adjuvant treatment, as well as post-prostatectomy failure cases in the management of locally advanced prostate cancer. Next slide. Is there any role of neoadjuvant androgen deprivation in patients prior to RP? Neoadjuvant androgen deprivation can decrease the post-operative positive margins. It can reduce the tumor bulk. It can decrease the biochemical recurrence, but there is no improvement in OS and cancer-specific survival. So it use as a routine thing is not generally recommended. Next slide. Adjuvant radiotherapy, it reduces, especially when combined with the brachytherapy boost, it increases the dose to the prostate and minimize the radiation to the surrounding tissue, thus reducing the adverse effect of RT. Next slide. Role of cystoprostatectomy in the management of locally advanced prostate cancer. We have systemic reviews. Next slide. So we have in that systemic review almost 7 studies with more than 200 patients. Cystoprostatectomy was done as a primary modality in locally advanced prostate cancer or as a salvage procedure. And next slide. So perioperative outcome pathological results are blood loss volume generally between 2000 to 5000 ml, and operation time generally from more than 8 hours, 8 to 9.5 hours, with a positive surgical margin seen up to around 60 to 70% of cases, and bladder invasion were seen in almost up to 80% of cases. All these patients had a Gleason score of more than 7, and there was an overestimated T-score of up to 60%. Next slide. So post-operative complication and survival outcome seen that the complications were seen up to 75% of cases, and distant metastasis were seen in around 77% of cases on more than 60 months of follow-up. 5-year cancer-specific survival was 87%, and 5-year biochemical progression-free survival was 62%. Next slide. Role of robot-assisted radical prostatectomy. Next slide. So here the blood volume loss is less compared to radical prostatectomy, which is around 400 to 500 ml. Complication, all grade complication at the rate of 8 to 29%. And oncological outcome, most of these patients were continent at 1 year, and almost the biochemical relapse-free survival were 50% at 1 year. Next slide. Role of androgen deprivation therapy in locally advanced prostate cancer. Next slide. Next slide. So, how to give ADT, whether immediate or delayed of ADT? Is surgical better than medical castration, or is it equivalent? Selection of agents, agonist or antagonist. All agents are equal or not? Role of combined androgen blockage and intermittent androgen blockage, is it safe or not? Next. So surgical castration as compared to medical castration, we can achieve castrate level of testosterone rapidly. Since there is no testosterone surge, there is no flare, so no prior anti-androgen required. And the issue, it is cost effective, and psychological element is there since surgery is done and scrotum is testis is removed. Medical castration on other side is the castration level is achieved late at the end of the 3 to 4 weeks only. There is a testosterone surge, and so flare can occur. So anti-androgens may require prior anti-androgens. Next slide. Both are equally effective. And compared agonist with antagonist, antagonist has a rapid onset of action of the castration level is achieved within 96 hours. No flare. PSA failure rate is 8.9% only compared to 14.1% with agonist. But there is a significant local injection reaction of up to 40%. Cardiovascular complication is almost similar. Antagonist is administered monthly, and the antagonist can be given for selected patients who needs rapid onset of action. That is the patients who present with severe symptoms or impending spinal cord compression, severe bone pain, or bladder obstruction. Next slide. The role of adjuvant ADT, long-term adjuvant ADT, long-term ADT improves the overall survival. It potentiates the radiation effect. It helps in the eradication of microscopic distant metastasis outside the primary. Next slide. So, regarding the optimal duration of ADT, there is no clear definition. Generally, in high-risk setting, long-term ADT is used. 18 to 36 months is used. This has got a longer biochemical failure-free survival and a significant OS also. Next slide. So, ADT in combination with RT, this is the main stay of treatment of locally advanced prostate cancer. There are various trial RTOG, RTC trials. RTOG 8610, which evaluated ADT plus RT, that is 2 months prior to RT and 2 months post RT, ADT was given. And compared to the RT alone group, the combination group, there was a significant reduction in disease-specific mortality, distant metastasis, and biochemical failure rate were also less in the ADT plus RT group. In ERTC 22863 and RTOG 8531, the duration of ADT was prolonged almost 3 years and more. Here also, there is a significant improvement in the disease-free survival, overall survival, and cancer-specific mortality improvement is also there. Next slide. So long-term ADT is better than the short-term ADT. Long-term ADT is generally 18 months to 36 months. Generally, most of the guidelines recommend 24 months of ADT. So the main problem with the long-term ADT is the side effects. It can be impotency, loss of libido, osteoporosis, so many side effects related to androgen deprivation. So this was compared long-term ADT 36 months with the intermediate term of 18 months. After 9.4 years of follow-up, there was no difference in distant metastasis, overall survival, and cancer-specific survival. These patients had significant improvement in quality of life. So intermediate ADT might be non-inferior to long-term ADT of more than 36 months, but this should be tested in a properly powered non-inferiority trial. Next slide. So RTOG 8610, as we have already discussed, randomized locally advanced prostate cancer. 1:1 randomization was done with ADT, 2 months prior and 2 months post RT, and RT alone. Next slide. Next slide. Next slide, please. So there is a significant improvement in the disease-specific mortality, as we see that there is a wide separation of curve in the ADT plus RT group compared to RT alone, and prostate cancer specific mortality is also significantly increased. The 10-year at 10 year, only 23.3% died of prostate cancer in the combination group compared to 35.6% in the RT alone arm. In the RTOG 96101 trial, there was 51% reduction in risk of prostate cancer specific mortality over 10 years in the combination group. Overall survival, again, there is a benefit, and all-cause mortality also, there is a significant improvement in the combination arm compared to RT alone. Next slide. GETUG AFU 16 trial, which randomized post-prostatectomy failure patients with the rising PSA. They randomized 1:1 randomization done with 6 months of ADT plus RT or RT alone. Next slide. Next slide. So there is a significant improvement in progression-free survival. 10-year progression-free survival was significantly increased, 64% 10-year progression-free survival compared to RT alone. Next slide. So, role of adjuvant chemotherapy, the multi-arm, multi-stage STAMPEDE trial, they had one arm with docetaxel, which was given before RT and long-term ADT. There was improvement in PFS and failure-free survival, but no significant improvement in overall survival. So this is under evaluation and investigation, and there is long-term follow-up is required to see where there is an overall survival benefit in this subset of patients. Next slide. So to conclude, in carefully selected patients with locally advanced prostate cancer, radical prostatectomy is one of the modality which can be tried as in a multimodality setting. There are newer options like robot-assisted radical prostatectomy, which helps in the management, which has better post-op outcome compared to radical prostatectomy. And ADT in combination with primary therapy has shown to improve improve the outcome significantly. Long-term ADT has shown clear benefit over short-term ADT. The role of neoadjuvant chemotherapy is under investigation, and there is not enough mature data to encourage the general use of adjuvant chemotherapy in a multimodality treatment setting at present. Thank you.
I must congratulate Dr. Nair for that lucid presentation. He's included everything in his crisp and precise presentation. It was a very nicely concluded and nicely brought out. He has gone in the details of all the recent advances and the recent recommendations. It was very nice. Thank you so much, Dr. Nair.
Thank you, sir.
And now I'll not stand between the audience and our great stalwart, Colonel Chaudhary, sir. We associate long since past, and I know he'll carry this show forward with a lot of learning again. Over to you, sir.
Not audible, sir.
Sir, you are not connected to audio. You are just connected to video. GS Chaudhary, sir, we can't hear you. Hello?
Just one
Yes,
second.
sir. Now we can hear you. Through your iPhone connection, we can hear you now.
You are now muted, sir.
So good evening to you, everyone, and welcome to this today's panel discussion. It's my proud privilege to introduce the 6 urologists of the Indian Armed Forces who are with us in this panel. And that is Colonel Amit Agarwal from Command Hospital, Western Command, who's a colleague of mine, and we're working in the same institute. Lieutenant Colonel Gagandeep Singh from Base Hospital, Delhi. Colonel Nimit Solanki from Northern Command, Udhampur. Colonel Praveen Lanka from Lucknow Command Hospital. Colonel Prasha from MH Jalandhar, Colonel Prashant from MH Jalandhar, and Colonel Tiwari from the Eastern Command, Calcutta. So I'll start sharing my screen, and I think we go straight to the presentation. So we are going to discuss on the role of androgen deprivation therapy in the management of prostate cancer today. And starting with the case, we have a 59-year-old male who initially presented to his physician with dysuria and other symptoms that were attributed to a urinary tract infections. The symptoms continued despite intermittently taking antibiotic treatment. And after 2 years, when his symptoms didn't subside, he thought there is something more sinister than just a urinary infection, and he approached his urologist for a second opinion. The urologist ordered for a prostate specific antigen. The level was 9.8 nanograms per ml. And subsequently, since it was raised, he asked him for a transrectal biopsy, which confirmed a diagnosis of clinically localized prostate cancer with a clinical score of T2 and a Gleason score of 4+5 of 9, which is high, and 4/4, 8 cores were affected. The patient was now given the options of either undergoing surgery by radical prostatectomy or by receiving radiotherapy by external beam or brachytherapy, and the patient thereafter opted to undergo surgery. The histopathological restaging confirmed that their prostate had the surgical specimen was of a pathological stage of T3 and had positive surgical margins. On post-operative follow-up, his PSA remained normal, but however, it started to rise after 3 months. So I would just take this to Colonel Amit. And Colonel Amit, how would you now approach this patient?
So basically, we have a patient who has a positive margin basically after a radical prostatectomy. And now his PSA has also started to rise after 3 months of the surgery. So here I would like to know first whether it's a local recurrence or there is a metastasis also. So whether it's a local failure or a systemic failure. That is the first thing I would like to know here, sir. Chaudhary sir?
म्यूट करके गैस में ये तो
Chaudhary sir, can you hear me?
Yeah, Amit sir, we can hear
you
you.
hear me?
Chaudhary sir, we just want to know whether it's a local failure or a systemic failure. If no investigation would have been done, then I would like to have a PSMA PET scan for this patient to know the same, sir.
I'm actually not getting the audio.
You can't hear me? Somebody can look into this, please. Ask him to log out and then log in again. I think that would help.
I'm not getting the audio.
Sir, you can rejoin.
Person you have called is speaking to someone else. You can. Hello.
Hi, Rovind. I'm not getting any audio. Yeah, I'm unable to communicate.
उसमें unmute का option नहीं आ रहा है.
नहीं, मैं unmuted हूँ, but I'm not able to hear Dr. Amit or anybody else.
So we can hear you, sir. Chaudhary sir, we can hear you.
तो वो आपको technical उसमें support करेगा.
GS, your voice is audible. We can hear you. Yeah, Amit, you are correct. One should first of all find out whether it is a local disease, localized recurrence, or it is a distant metastatic disease, because the treatment option will be different in both the cases. So I don't know whether the PSMA PET was done in this case, because but suppose it is a localized disease only, then what will be your option? And if it is a distant met, then we can switch on to the next panelist. Amit, you are mute. Amit?
Sorry, sir.
Yeah.
I'm sorry. So I'm saying if it's a localized disease with PSA rising and a positive surgical margin, ADT plus RT to the pelvis would be the right option for him, I guess.
Okay. And suppose it's a distant met.
So distant met, so ADT alone, sir, without RT.
Okay.
So would you like to go in for a, can I put in a query, Amit sir?
Yes, please.
Yeah, I'm sorry. Yeah, I think I got it.
So you'll have to log out from one device.
Yeah, I think I'll request if you can share my slides, because I'll request the technical support if you can share my slides, please.
Yes, now you are audible.
So I've logged out from the other device, so I don't have the slides on this. So if the technical support can just share these slides.
So by the time they put up the slide, Chaudhary sir,
Right.
you there?
Right. So should I take it forward meanwhile?
Yes, sir. So basically my query was whether it's a local failure or a distant failure. So I would like to know whether a PSMA PET scan was done for this patient or not, sir.
Yeah, a PSMA PET scan was done for this patient, and there was no evidence of any distant Mets.
Okay, so we have a localized disease with positive margin and PSA which has started to rise. So
Yes.
another query here which I want to know is that did we offer any adjuvant therapy to this patient after the surgery when we noted that the margins were positive, or we waited for the PSA to rise before acting?
The patient actually did not, for the next 3 months, he preferred not to undertake any adjuvant therapy. He had some logistic issues and followed up at 3 months with the PSA. So he got nothing in that intermediate period.
So in that case, my option of choice would be ADT plus radiotherapy to this patient.
Okay, so let me ask you that why would you choose to give a combination of both? Because we have known from various studies that RT alone was being used earlier. Is there some practice changing event which has happened? No.
Sir, the disease-free survival and overall survival is better if we add ADT in such cases.
Yes, I think you're correct. Would all the rest of the panel members agree to this approach?
Sir, I'll request other panel members to also switch on their video so that we can have them on the panel.
Yes, Colonel Gagan, Colonel Nimit, Praveen, Prashant, Manu, please switch on.
Sir, I'm on. I think. Can you hear me, sir? Because my video and audio
Yes,
is unmuted,
yes.
and I'm on, sir. So, sir, I would like to know in which order would you like to go in? Would you start off with a ADT followed by RT, or would it be a RT followed by a reassessment by an imaging with ADT, continuation of ADT, or will it be a concurrent approach?
So yes, that's what I would like you to answer. That what would you do if this patient had come to you?
Sir, with a positive surgical margin and local recurrence, with the patient not following up for 3 months and imaging showing only local recurrence, I would like to go in for a RT alone, sir, because as Amit sir is saying that both approaches would increase the overall survival. So sir can tell us more about that. But I think I'll go in for EBRT in the first place, and maybe a repeat imaging to look for whether that recurrence has been taken care of, and follow up with the PSA. And if the PSA is still rising, then maybe I'll go in for the ADT, sir.
So we already have PSA which is rising in this patient. So there is a positive surgical margin with PSA rising. So if you look at, he's come to us after 3 months, and as far as the timing of ADT is concerned, it can be given with RT either before, concurrent, or subsequent to RT. All 3 forms of ADT with RT gives you a good result rather than RT alone.
Yeah, that's true. So would anybody like to differ, or if you agree, then we can go on to the next slide. So the next slide.
Gagan has messaged me, sir. He'll join in 5 minutes. So
no
he's busy somewhere.
So as we can see, the various guidelines tell us exactly what Dr. Amit Agarwal has told us, that if he's in a high-risk group, then definitely we will like to go with ADT and radiotherapy together. Now, there is some theory behind this. They say that ADT is not only cytoreductive, it not only increases the oxidative stress, but it's also synergistic with the radiotherapy. And ADT also is supposed to, rather than acting like a radiosensitizer, also controls the micrometastatic disease. So all studies have shown that ADT and RT is the standard of care. And various studies have shown, next slide, please. Next slide, please. Yeah. Shown that in our case in particular, we have a patient who had positive margins. So with the positive margins, obviously the recurrence rates locally are much higher. And we are worried about this, which we hope will be controlled with a local treatment like radiotherapy. And since the Gleason score is 9, which is a very high score, and there's a risk of distant metastasis, and hence we add ADT. Next slide, please. Next slide. So we've already covered this. What will be the treatment approach next? And we have home down to the, obviously there is no option of observation in such a patient. I'm sure nobody would go in for just surveillance or observation. And gone is the era when radiotherapy alone or ADT alone was the treatment, and radiotherapy with androgen deprivation therapy. My next question is, next slide, please. Which ADT would we choose? Would we choose an agonist or would we choose an antagonist, and why?
Chaudhary sir, there is a comment in the comment section in the chat box by Nishant Lohia. If he's there, he can speak up, sir, so that we can add to the discussion here, sir.
Yeah,
because you're on the mobile, you're not able to see that.
Yes. Yeah, good evening, sir. Am I audible, sir?
Yes, you're audible, please.
Yes, sir. Just I would like to bring out 3 points here, sir. Irrespective of the, I'm talking about the local disease status in a post-radical prostatectomy scenario. We give adjuvant RT. Either it is in the form of early RT or delayed RT. Now, in this case, since the margin is positive with positive seminal vesical invasion and even detectable PSA, which is more than 0.2, which is 0.5 here. So definitely he is a candidate for adjuvant RT. I don't know about the lymph node status. Basically, if PSMA PET, he has undergone post-radical prostatectomy.
Lymph nodes are not involved.
There are no lymph nodes involved. So then
N0.
EBRT takes precedence over ADT. Then we can straight away start EBRT, and with definitely adjuvant ADT can be given for another 2 years based on those high risk factors.
Right.
But if there are lymph node mets, then ADT takes precedence over RT. RT can be given depending on the regional risk, but ADT definitely has to be given prior to RT, and then kind of neoadjuvant hormonal therapy followed by continuation of RT followed by adjuvant ADT in localized such a scenario, sir.
That is correct. So now I would I'd like to ask Colonel Manu that which ADT would you choose and why? Is Manu with us?
I'm not sure, sir.
Manu is not there. So Praveen, Colonel Praveen, would you like to take this up once again? Which ADT would you choose and why?
Sir, either the agonist or antagonist, but depending upon whether there are any symptoms or he is a risk candidate for flare phenomena, I think both agonists and antagonists are equally effective. It's what I think, sir. And I would like to go in for agonist because basically based on availability is what agonists are more easily available. And since antagonists, that degarelix is like monthly dosage and with more injection site problems. So I think agonists will be more easy. And since especially in this patient who is less likely to follow up every month because after the surgery he was for some problems he could not follow up. So it would be more logistically convenient for this patient. That's what is my opinion, sir.
Yes. Anybody would differ?
I would agree to what Praveen has said. And other thing which may be a bone of contention here is the cardiac risk status of the patient. So if the cardiac risk profile is not very favorable, then antagonist scores over agonist in such patients.
Right. So yes, generally in the real world setting, because of the initial surge with the agonist, we would be only worried about, something like spinal cord compression or bladder neck obstruction. Our patient in the current discussion doesn't have any cardiac comorbidity, and the side effects are comparable between both. So we could use, in a common setting, we would use an agonist, and many times to prevent a flare, we would give some duration of anti-androgen therapy starting a week, 2 weeks before, and continuing for about a month after to prevent this flare. That is the only thing. Otherwise, the adverse effects are comparable. And
sir, sorry to interrupt, sir.
Yes,
as you just said, sir, that to prevent flare phenomena with the agonist, we start off probably bicalutamide is what you're talking about, sir, to maybe a week or 2 weeks. But there have been some recent studies which say that they can be given concurrently also. It does not require to be given 1 week prior. So I would just like to ask the opinion of the house on that one, sir. And is it really beneficial nowadays to start off bicalutamide?
So in fact, the practice today is to start concurrently and taper off the anti-androgens after a week or so.
Yes, sir. So we start off with
Yeah.
the 150 mg, then maybe 50 mg once a day, and then after 7 to 10 days we stop. 4 weeks we stop off.
Yes, but yes, and that's
7 days generally, 7 to 1 week to 2 weeks, not beyond that.
Okay.
And what would be your duration of therapy after, let's say we have chosen Zoladex or Goserelin subcutaneously, and we have, the patient says, instead of coming monthly to the hospital, I would like to come once in 3 months. So we have chosen the frequency, we have chosen the drug. Now, how long do you suppose should be the duration of giving this? Once he's got a biochemical failure?
I think we continue for at least 2 years, sir. Ideally, it should be continued lifelong, but after 2 years, if his PSA is much under control, imaging does not show any further avid lesions, then we can, I think we can put him on a intermittent ADT therapy to continue for life.
Sir,
So I think
this is
Amit sir can
Yeah.
So this is a gray area, sir. The exact duration of the therapy has not been clearly defined in any of the guidelines, sir. But it is said that a definite to 36 months or three years of therapy is to be given. Beyond that, it is not defined, but generally in our clinical practice, we are giving lifelong to such patients.
Yes. So we'll go to the next slide. Next slide. Yeah. So here we have already discussed that although leuprolide as an agonist will be better than degarelix as far as the PSA progression-free survival is concerned. Next slide, please. And we have seen that the injection site reactions were more common with an antagonist compared to an agonist. Other adverse effects were almost similar between both these drugs. Next, please. No, both these group of drugs. Next, please. Yeah. So all trials have generally shown that agonists were the drugs to use. And using oncological endpoints, a CS21 study was the only one which had studied oncological endpoints. Others had mainly looked at the side effects in others. And like I've already mentioned of cord compression and bladder neck obstruction, or when there's an urgency in reducing the size of the prostate or reducing the levels of testosterone, then degarelix gets the upper hand. Next, please. So, so we gave this patient an agonist, and the duration as per various trials is very confusing. Actually, if you see the 8610 trial, it gave an advantage of a 4-month ADT. And then came the RTOG 9202, which showed that 28 months was better than 4 months. And finally, there are 2 EORTC trials, 22863, which showed 3 years of ADT, had a 10-year OS advantage of 58% versus 40%. And again, this was reconfirmed in the EORTC 22961 also. So as we can see that the longer the duration of ADT, the benefit of OS was definitely there. And now we'll come to the other thing that when we give radiotherapy, would some of you be using or referring your patient for even brachytherapy, or would you just prefer external beam radiotherapy for a T3 high risk operated prostate with biochemical failure?
Sir, it is EBRT is the treatment of choice, but with if you give a boost, brachytherapy boost along with EBRT, it is shown to have a better result, I guess.
Right. So,
sir,
yes.
Can I point out one thing, sir, here? Sir,
Please.
it is a post-radical prostatectomy case. Generally, when we give upfront definitive RT, then EBRT along with brachy boost comes into the picture, since it is a post-op scenario. So in a post-op scenario, generally we give either adjuvant RT or salvage RT if we give it for biochemical failure, in such case where 3 months delayed RT is given. So in such case, generally we can restrict ourselves to post-op RT to 64 gray rather than giving brachy boost, because brachy boost we don't know, because otherwise in definitive therapy we give boost to the prostate disease in such a case where there is a tumor bed. So it will be a big tumor bed. So brachy boost is not preferable. It's EBRT alone, sir.
Okay. Thank you so much. Thank you.
So that's he was a radiation oncologist, right? No.
Yes, sir. I'm the radiation oncologist.
Okay. Yeah. So we have to take your word for it. And our understanding as physicians is that mostly, I think you would give 50 grays to the pelvis when you're giving definitive, and 20 grays boost you'll give to the bed.
Yes, sir. So generally 46 to 54, we go for the pelvic RT with the prostate in the nodes, and then we boost the prostate only area for last 20 gray.
Right.
Okay.
So that next slide, please. Next slide. So these are the various trials. I've already mentioned this. Next slide, please. So 24 to 36 months, it's controversial. And in the real world, we practice both 2 years or 3 years of ADT. And there are a lot of quality of issues which the patient may have. There's some quality of life issues, maybe the ones like hot flushes, or his getting emotionally labile, or getting depressed, or having a lot of cognitive issues which are manifested and which are immediately disturbing to the patient. But there are some other silent issues which keep happening within the patient, like let's say his cardiovascular health becomes worse, and he may land up with even a cardiovascular or cerebrovascular event, or he may get gradual bone loss. He may develop obesity, and he may develop sarcopenia, which is, thinning skeletal muscle loss is there. So this happens over the long term, and we have to actually tailor the treatment and have a long discussion with the patient, whether he can come to hospital daily. If he's anxious and he wants to meet the doctor every month, then we have to shift to a monthly dosing. If he doesn't want to come, he wants to come once in 6 months, there are even 6 monthly preparations which are available. So we have to look at the quality of life and what is the expectancy we have. And we have to remember this is a non-metastatic setting so far. Next slide, please. So the patient received 70 gray. I think the radiation oncologist differed from what was said earlier. And he gave him 70 grays over 6 weeks. And this was preceded by Zoladex subcutaneously in a 3-monthly schedule. And the PSA level remained stable and was less than 0.2 nanograms for a period of 2 years. After 2 years, there was some biochemical failure with a rising PSA. Next. Next slide, please. Yeah. So now, how would we approach the patient once he's getting a raised PSA after this treatment has, after 2 years, been given for at least 24 months to 27 months?
So first thing, would we do a serum testosterone level to see the castrate level of the patient, sir, whether it is we have achieved the castrate level or not, sir.
So what would be your cutoff of testosterone? Would it be 50 or would it be 20?
So generally we consider 50, sir. I'm not sure whether we are considering 20 or not these days.
So nowadays, as oncology nerds, we go in for 20 because the techniques which did it earlier were more generalized and they would cut it off at 50. But now we understand that 20 is the cutoff to take. So anything below 20 is acceptable as testosterone being castrated. Medical castration has been achieved.
Okay.
And then how would you proceed with this imaging and all?
So again, a PSMA PET scan here to look for local versus systemic failure again at this stage after 2 years of therapy. And if there is no systemic failure, or if it depends on whether there is systemic or not. Sir.
Right. So has anybody got any experience with the carbon-11 dated choline PET scan? Do we have it available anywhere in India or armed forces? And at least I'm not aware if it's available in the armed forces.
These choline peaks are being done when these people are getting the PET scans. It is being done, sir. I'm not sure whether
where it is available.
Asking for it or not, sir. But it is being done. Sir.
Right. So we'll go to the next slide.
One question, sir. In this patient,
right.
Am I audible, sir?
Yes.
In this patient, ADT has been given. Was it a combined this thing with the anti-androgen also, sir?
No, this was just plain Zoladex, goserelin alone, 3 monthly, and that was for 2 years.
Chaudhary, sir, please. Clarification from your side for the benefit of the audience. What is the role of combined androgen blockade in today's world, sir? Are we following it, or we just use agonist alone without an anti-androgen?
Well, in this particular setting, when the patient was non-metastatic, we would have actually...
Otherwise, sir, not restricting to this setting alone. Otherwise, in general, so what is the consensus?
In general, actually, it is gradually losing its importance. That initial flare, which much was talked about, has now actually been only restricted to 1 or 2 settings. Like if there's an impending cord compression and we are worried about quadriparesis or paraparesis, or we are worried about a bladder neck obstruction, then yes, we would give it for a week or 2 weeks at the max. But it is more or less, we can give ADT goserelin as an alone also.
Absolutely, sir. So we, in our clinical practice, we have changed from a combined androgen blockade to a monotherapy with GnRH agonist alone. So, because
actually, my query in this situation was because patient has presented to us with rising PSA and being on ADT, so one should be cautious if they are on combined androgen blockade with the bicalutamide. So at times after stopping bicalutamide, PSA may fall again.
True. Very true.
One quick point, sir, if I may come in.
Please.
Yeah, sir. One is regarding labeling this patient as CRPC, as there was some discussion. I think the guidelines. Hello.
Hello.
Am I audible?
Yes, I can hear you. Yes, I can.
Yeah. So I think to label this person as a CRPC, castration resistance prostate cancer, I think, do we need 2 serial PSAs? According to the definition by EAU, it says that testosterone in castrate level, that is 50 /20, whatever be the this thing. But as far as I remember, it was 50 only. And there should be 2 serial PSAs, which should be more than 2. And ideally, between these 2 values, it should be double of the previous value. That's what by the definition was considered. So are we following it by the strict guidelines, or one rise in PSA with testosterone and castrate level is good enough to call him a CRPC?
No, I think
my apologies. You are left with just 4 minutes to conclude the panel discussion. Thank you.
So we'll do that. We'll come back to your thing. I think we should not base it based just on a single PSA level. Can you go back to the previous slide, please? So a computed tomogram showed and a bone scan revealed pulmonary mets, but there was no bony metastasis, which is again odd for a prostate cancer. A lung biopsy then revealed moderately differentiated metastatic adenocarcinoma. Next slide, please. So as we can see, the arrows are showing you definite pulmonary nodules. And like Lanka had brought out, this is a hormone-sensitive metastatic disease. And the shrinkage of pulmonary metastasis were there in response to bicalutamide, which was added now. Next slide, please. So how do we manage the patient who has got a metastatic disease now and is hormone sensitive? Would one of you please take it up?
So basically the options are whether we want to add anti-androgen now if it was not added earlier, or we want to add abiraterone to it, or we can also add a chemotherapy to it at this point in time. So all the options are open to us.
Yeah, including, I think, chemotherapy with androgen deprivation. Again, we can.
Absolutely, sir. Absolutely. So, in combination.
There is a lot. Yes.
I think irrespective of whatever we do, ADT has to continue. That I think we all agree on that.
Yes. Right. So as we can read, metastatic hormone-sensitive prostate cancer is a disease where men have prostate cancer and have never received androgen deprivation therapy. So I think beyond this, we'll go to the next slide, please. Next slide, please. Yeah. So for this patient, then the options would be either continue ADT with chemotherapy, and continue ADT with abiraterone. And the appropriate use of these drugs will double the median survival to at least 5 years. Next slide, please. So NCCN guidelines also do give one of these regimes. Apalutamide is not available with us. Abiraterone, docetaxel, enzalutamide, all can be given, and the patient should be followed up with a PSA serial imaging every 3 to 6 months. And as brought out earlier, we should not look at simply one PSA value. Next, please. And I think I've come to my last slide. So basically, what we want to highlight is that in a locally advanced cancer prostate, which was like a T3 disease in this particular patient, and in other groups of patients also who have local disease, various studies have shown that whether it is a T3 disease, it's a bulky, even T2B also. And many have taken T2C to T4, or if it's margin positive, or if the Gleason score is more than 7, a PSA of 10 or equal more than 10 should get around 66 to 70 grays of radiotherapy, along with androgen deprivation therapy is the final hot point, end point which I want to give. And also want to mention that we must individualize the management of such patients according to the side effects and their expectancies. So the urologist, medical oncologist, the radiation oncologist, and the surgeon, it is a teamwork. And we all must sit and, as a disease management group, look at what best we can do for this kind of a disease, which is not going to immediately, harm the patient, but it may bring significant morbidity. And maybe the biggest thing for the patient may be just his, penile erection, and his mood may be bad. So we have to tailor the treatment depending on the patient. And a lot of new drugs are up in the horizon. And I'm sure we have had a healthy discussion. And I thank all the participants for giving their contributions. And I now hand over the stage to the audience and the chairperson, and for the concluding remarks, please.
Thank you, sir.
Thank you.
Sir, that was a very session with a lot of information and practice guidelines. I'll request the Jan Kapur sir to conclude the session and ask the next session to start.
Yeah, thanks a lot, Amit. And it was a very nice discussion on the management of prostate cancer, locally advanced. And I congratulate all the participants in the panel discussion and the speaker for very nice discussion. And thus we finished the first part of the session. And now we will move on to the second part of the presentation. And to chair the next session, I invite Colonel T. Suresh, who is the HOD Medical Oncology at Army Hospital, RNR. Colonel Suresh, are you there?
Yes, sir. I'm there, sir.
Yeah, Colonel Suresh, welcome to the session. And I request you to conduct the next session and chair the session.
Thank you, sir. And thank you to the organizers of this conference, and a very good evening to all my seniors and colleagues in this conference. So the next session will be on HRR, homologous recombination repair or testing. And we have two eminent speakers in this session. And we start with Dr. Colonel Anurag Mehta, who is the director of the Department of Lab Sciences and Research at Rajiv Gandhi Cancer Institute in Delhi. He has been one of our beloved teachers in the Army, and since retirement, he has been at Rajiv Gandhi Cancer Institute. He has a special interest in molecular biology and diagnostics, the testimony to which is borne out by a state-of-the-art molecular diagnostics lab rated as one of the most advanced labs in the country. He is also the editor-in-chief of the Journal of Current Oncology and has more than 150 papers in national and international journals. So I think he is the best person to tell us about the nuances of HRR testing, whom to test, when to test, and what to test. Anurag Mehta, sir, please.
So, thank you, Suresh, for your kind introduction, and good evening all. And this evening, I will speak to you on homologous recombination repair pathway and how does an impairment of the homologous recombination repair pathway results in several cancers, and what is the need to do homologous recombination repair pathway testing, and the nuances of these testing that will answer the questions which have been assigned to me by the organizers. So I will briefly speak about what is homologous recombination and then try and answer these questions which have been assigned to me. So we know that our DNA is continuously being damaged by endogenous and exogenous insults. The endogenous insults are in the form of reactive oxygen species, spontaneous deep urination, alkylation, oxidation, the errors of replication. Exogenous insult can come in the form of ionizing and non-ionizing radiations, the genotoxic agents in the food, environmental pollutants and cigarette smoke, etc. And each cell of our body suffers 1,000 to 1,000,000 DNA damages a day. and this needs to be repaired. And these repair pathways are absolutely very efficient and very effective. So there are several pathways which participate in the DNA repair, but of importance to us today are the single strand break repair pathway and double strand break repair pathway today. The single strand breaks are repaired by single strand break repair pathway and base excision repair pathway. These are simple repair processes because we have a complementary strand which is available as a template to fill this gap and bridge the gap. On the other hand, the double stranded breaks are difficult to repair because we do not have a complementary strand. And nevertheless, the repair does occur, and it occurs by a process called homologous recombination. And when the homologous recombination fails, the repair is still carried out by what is called as a non-homologous end join. So let's see what is homologous recombination. In the process of homologous recombination, when there is a break, double stranded break, a complex which is called mRNA complex of protein is brought in. This complex then brings in more friendly proteins which splint the break so that the strands don't collapse. And it also creates these overhangs. Such 5' to 3' overhangs are created. And then other companion proteins are brought in. These companion proteins finally culminate in bringing in RAD51. The RAD51 is the final effector protein. It is a filamentous protein. It coats the overhangs and then insinuate the sister chromatid where the homologous strand lies. And after invading the homologous strand, then it uses this strand for the repair and carries out a repair which is an exact replica of the original. So the DNA is returned into its pristine state. And this process is very efficient, very effective, and requires about 15 proteins to participate. Of them, BRCA1 and BRCA2 are the most crucial proteins, apart from several other proteins like BRIP1, BARD1, ATM, CDK12, CHEK1, 2, etc. For whatever reason, if this pathway is not functional, if this pathway is ineffective, then the repair happens what we call as a homologous recombination deficiency. Then the repairs occur through what is known as a non-homologous end join. The non-homologous end joining is a simple process in which the two broken ends are identified by two proteins, a heterodimer of Q70 and Q18. They identify this site of break. They carry out the removal of the overhangs, and they ligate these two ends by using ligase 4 and XRCC4. Now, what happens in this pathway is that we are losing some genetic material. The genetic material has been removed, and the two ends, after removing the genetic material, have been polished, blunted, and tied up with each other. So, but what has happened? There has been a loss of genetic material. The reading frame has altered. And once the reading frame alters, this is something like a mutation. So this process is mutagenic, and hence it is carcinogenic. And this homologous recombination deficiency has been identified to be responsible for several cancers, most significantly breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer. And as far as the prostate cancer is concerned, 23% of the prostate cancer are initiated by homologous recombination deficiency. And this alteration is a driver alteration and occurs early. And this is an important point to remember for the purpose of testing, that this is not an evolutionary change, but this is an initiating change. So in summary, there is a loss or dysfunctionality of one of the HR proteins which make the HR pathway ineffective, leading to repair by non-homologous end joining, which is carcinogenic. But that brings us to the question, why is there a loss or dysfunctional HR protein? And this is because of several genomic perturbations. And these genomic perturbations can be in the form of germline alterations, where a mutation is running in the bloodline and has come from one of the gametes, the spermatozoa or the ovum, and this mutation is carried by all the cells of the body. In certain instances, this can be a somatic inactivating mutation in one of the genes coding for these proteins. And in this case, the alterations are seen only in the tumor cells and not in all the cells of the body. And then this protein can also, the genes encoding for these proteins can also be silenced by epigenomics, like promoter methylation of the promoter sequences, which results in no protein, though there is no mutation, and this change is also seen in the tumor cells. So with this knowledge, we will see what are the attributes of a cancer which have germline genetic alterations, and what are the attributes of the cancers which have a somatic genetic alterations. So those cancers which have a germline genetic alteration, they account for about 11.8% of all the metastatic prostate cancers. And the germline HRR mutations are associated with aggressive phenotype, higher stage at diagnosis, and inferior survival. So 1.6 to 3.8% of the prostatic cancers which are low risk have germline mutations. On the other hand, the metastatic prostatic cancer have these germline mutation to the extent of 7.3 to 16.2%. And most of these germline mutations happen in BRCA2, ATM, and CHEK2. They're followed by BRCA1, PALB2, and RAD51D. Now, because these are germline mutation and one expects that these are traveling in the bloodline, but that's truly not the case. So one cannot actually find out those cases who may have germline mutations solely by the family history of prostatic cancer or other related cancers. 46 to 67% of the patients have no family history. And this is important for finding, for determining who shall be tested for germline mutations. And the germline mutations are tested on blood and buccal swabs. And these germline mutations have predictive value. That means they help us in deciding or choosing the therapeutic options. They also are prognostic markers because patients with germline HRR mutations have aggressive phenotypes. And it is also used for finding the predisposed in the kindred of the patient who had prostatic carcinoma. That means for the purpose of family screening. Now, as far as the somatic mutations are concerned, they're seen in 19% of the localized prostate carcinoma and 23% of the metastatic castration-resistant prostate cancer. Just about double the numbers that you see that you see with the germline mutations. So for somatic mutation, we carry out testing the tumor specimen. But remember, when you test the tumor specimen, that will also show up the germline mutations. So when you find a mutation in the tumor tissue, about half of them are actually of germline origin. And this, the physician treating the patient should be aware of. The somatic testing is useful because it increases the pool of patients who can receive PARP inhibitors. On the other hand, the germline testing is uninformative for the mutation that has specifically occurred in the tumor. The somatic mutations are useful only as a predictive and prognostic marker, but not for carrying out the family screening. So what are the various HRD tests that we have? So as far as finding the inactive genomic alterations are concerned, we can use a germline test using an NGS panel. And for this, we will need blood or a buccal mucosal swab. For somatic testing, which is again done by NGS, we use the tumor tissues. And remember that they will carry the germline mutations apart from the somatic mutations. It should also be remembered that the testing of tumor tissue, one may not find the big indels, or big indels means big insertions and deletions or large genomic rearrangements, because the processing and preparation of a formalin-fixed paraffin-embedded section results in breakage of the DNA. And for big indels, one shall carry out the testing on blood using multiplex ligation probe assay to find out the big germline indels, which can then be used for as a predictive marker for use of PARP inhibitor. As far as the promoter methylation is concerned, it is mechanistically significant, but it is of no clinical use, and we don't test it as yet for making any therapeutic decisions. And then there is a surrogate test which is available, which finds the pieces of evidence of a failed homologous recombination repair pathway, where we see the genomic scars of double-stranded breaks. And these can be seen in the form of loss of heterozygosity, telomeric allelic imbalances, and large state transitions. This test is used for as a predictive marker in ovarian cancer. However, it has not been used as a predictive marker in prostate so far. And the last category of tests that one can do are the functional assays. These functional assays are to demonstrate that there is a loss of the function of a DNA repair in presence of a particular mutation. These are used only for the research purposes and in settling what is called as a variant of undetermined significance to figure out whether it is pathogenic or not pathogenic. So in common parlance, when we do a germline or a somatic test, we call them HRR testing. And when we look for the genomic scar using this proprietary test, we call it HRD testing. But this is just a colloquial usage, not on the basis of any scientific data. So why do we test? So we test, number one, because the individual or the patients with homologous recombination deficiency can be treated or selected for treatment with PARP inhibitors in metastatic castration-resistant prostate cancers. And it has been shown that 60 to 80% of homologous recombination deficient patients will demonstrate clinical benefit on use of PARP inhibitor, while those which are homologous recombination proficient, only 6 to 9% of them will exhibit a clinical benefit. And we all know that the PARP inhibitor basically block the PARP, which is a polymerase called poly-ADP ribose polymerase, required for repair of the single strand breaks. Once the single strand break is not repaired, during replication, it is converted into a double-stranded break. And in the setting of a deficient homologous recombination repair pathway, no repair of double-stranded breaks occur. And these double-stranded breaks accumulate to the extent that a sublethal injury becomes a lethal injury, resulting in cell demise.
My apologies, sir. You are just left with 1 minute to conclude your presentation.
Okay.
Thank you.
So the PARP inhibitor there are two approved PARP inhibitor, olaparib and rucaparib. For olaparib, we need to test the entire HRR set of genes, and for rucaparib, we can just test BRCA1 and BRCA2 in both germline as well as somatic setting. Now, this is also important from the point of view of prevention. Let us say this is an index case of a prostate carcinoma. Once is tested for germline mutation and is turned out to be positive, let's presume for a BRCA2 mutation, then we will extend this testing to his kindred, the first degree relatives, and it is expected that 50% of them will be positive. So we will find 3 more positive, and this we will do by testing only for this mutation and not for the entire HRR panel. So this is a very cost-effective process and allows us in finding large number of kindred who are mutation carrier and at a risk of suffering prostate cancer and other hereditary breast ovarian cancers. And why is it a very powerful preventive strategy? So if, for example, in a general population, if we do the screening, we will find 1 positive out of 800 individuals. While if we test 100 cases of prostate carcinoma, we will find 12 patients positive with the germline mutations. And if we have 4 family members to be tested, we will test 50 individuals. Of them, 25 will be positive. And to find 25 positive in general population, otherwise, we will need to test 20,000 individuals. While here we test only 50 individuals, that too with a site-specific test, specific for the mutation that we have seen. And these are the instances. So we have to do germline testing for all cases with metastatic disease, loco-regional disease, with very high-risk disease and high-risk disease. Patients who do, or individuals who do not have a prostate cancer, they can also be tested provided they have this family history. And you can find this in the NCCN guideline. And then again, the prostate cancer, patient with the prostate cancers who are intermediate risk, but have intraductal or cribriform histology, or who had a personal history of a pancreatic, colorectal, gastric cancer, melanoma, etc., are also the candidate for germline testing. So the choice of test for predictive use, it is the somatic testing and tissue biopsy, and especially the latest biopsy is preferred. However, as I said in the beginning, that these alterations are early and archived tissue is as good as a fresh tissue in case the fresh tissue is not available. The bone biopsy must be avoided. If tissue is not available, try liquid biopsy. If the liquid biopsy fails and you are unable to extract enough DNA, at least do germline testing if it has not been done earlier. You will still find about half the cases who can be treated with PARP inhibitors. And one question you must always ask the lab, if you find a low variant abundance, you find some mutation which is happening at 7%, 8%, 9%, shall you use this information for therapy selection? So there are passing references that any mutation or alteration that has been seen at less than 10% should not be used for therapy selection because it is likely to be a false positive, an artifact of PCR or sequencing. And because tumor testing cannot identify large genomic rearrangement, it is my suggestion to all oncologists that they must always combine the somatic testing with MLPA for BRCA genes on blood, because 10% of BRCA2 genomic pathologic genomic alterations are in the form of big indels or large genomic rearrangement. And the last question is, what shall you test? Shall you test for all 15 HRR genes or just the BRCA2, BRCA1 and ATM? In United States, the recommendation is to test for all the genes. In United Kingdom, it is for BRCA1 and BRCA2 only. In Canada, it is for BRCA and ATM, while in India, we generally follow what happens in United States. And in case, as I said earlier, tissue biopsy is not useful. You can use liquid biopsy, tissue is not available, or it is a bone biopsy which is not yielding result. You can use liquid biopsy. Sensitivity of 60% to about 90% has been seen. It's a good alternative. And if this also fails, then at least do the germline testing. And as far as the germline testing is concerned, it is primarily for preventive use, but it can also be used for as a predictive marker. When everything else fails, it is simple to handle, results are more reliable, and it will identify big indels. And as I said earlier, genomic scars is not used in prostate cancer. And what is the time when you shall test? Well, you can test at the time of diagnosis, you can test at the time when the first metastasis has happened. But I think the most ideal time will be when the first line of treatment in metastatic prostate cancer has failed and one has the option of using PARP inhibitors. So I will give this a go. And as far as the germline HRR testing is concerned, there's some recommendation. Usually 2 counseling should be offered 2 to 4 weeks apart. Blood should be taken at the second session, and results should be given 3 weeks later with post-test counseling, and positive cases should be encouraged to inform the relatives at risk and motivate them to obtain mutation testing. We generally report the germline testing in pathogenic, likely pathogenic, variant of undetermined significance, etc. The pathogenic and likely pathogenic should only be used for family screening and for use as a predictive marker. A good and a smart lab shall keep an account of the variant of undetermined significance and periodically review it, let's say at each 6 months. And if there is any change of status, this should be informed to the patient and his physician. And for somatic testing, the reporting is done as a tier 1, which is of strong clinical significance. That means you can use it for therapeutic intervention. Likewise, you can also use the tier 2 for therapeutic intervention. which is of potential clinical significance, but the variants of unknown clinical significance and benign or likely benign variants are not used as a predictive markers. So with that, I will conclude. I have overshot the time, I know, but HRD testing is essential in prostate cancer from the point of view of making therapeutic decisions, because PARP inhibitors have shown a median PFS benefit of about 4 months, as well as an OS benefit of about 4.5 months, despite large crossovers from the other arm. And therefore, PARP inhibitors are useful. And more significantly, I think you can find many healthy mutation carriers who can be given risk reduction strategies and a normal lifespan. Thank you so much.
Thank you, sir, for this wonderful talk. I think your talk has shown us that clarity and brevity comes from extensive knowledge. And though I'm sure there will be a few questions to your talk, unfortunately, due to lack of time, we'll proceed to the next talk. But I would like to request you to stay on to the panel discussion. Maybe a few questions can be taken during the panel discussion. So next we go on to our next eminent speaker is Dr. Colonel Deepak Mulajkar, who is Associate Professor of Medicine and Medical Oncology, and is a colleague of mine at Army Hospital in Delhi. He has a keen interest in basic sciences and research, and he is also an academician and a clinician par excellence. He has done a lot of work on prostate cancer at our center, and he would be the ideal person to speak on the clinical implications of what Dr. Mehta has told us, that is HRR, in the management of castration-resistant prostate cancer. Dr. Deepak, please.
Thank you, sir. Am I audible and slides are visible?
Yeah. Yes. Yeah.
Okay. Thank you so much. First of all, sir, it was a great lecture which was preceding mine. And after that lecture, I think this will be just a kind of a quite a, I won't be able to live up to those standards, but I'll anyway try. So presently, after having heard about HRR and HRD, so we'll now go on and see what are the clinical implications. For this, mostly I'm presenting to you the PROFOUND trial. Now, basically the epidemiology, all of you know about prostate cancers. Then we all know that mostly all the patients with metastatic prostate cancer at some point of time certainly go on to develop a castrate-resistant prostate cancer. And the overall median survival for these patients remains poor. So despite significant progress in systemic therapy, and we keep getting new molecules every day, the therapy seems to be inadequate at certain times. And in these cases where we find that 30% of patients harbor some alterations in DNA damage repair genes, including HRR genes. So these are the targetable lesions that we have come to know. We have seen this in ovarian cancers. We are seeing it in breast cancers. We are seeing now in prostate cancers. So we have two candidates here. We have rucaparib as well as olaparib. Presently, I'll take you through the PROFOUND trial once. And PROFOUND trial basically was a randomized open label trial, which was olaparib versus new hormonal agents according to the treatment choice. So the inclusion criteria were metastatic castrate-resistant prostate cancer. You had HRR mutation. This was done by Foundation One. They had tied up with Foundation guys, and probably they used that. As usual, the ECOG was PS 0 to 2, and they basically divided into two cohorts, cohort A and cohort B. Now, as we all know, there are about 15 genes, but the majority, as we have seen in the previous presentation, are BRCA2 followed by ATM, and then subsequently probably BRCA1. So these were the cohort 1 where the chances of getting a positivity were high, and the other genes that are involved in HRR were grouped into the cohort B. So basically, it was a 2:1 randomization with the olaparib versus physician's choice. Physician's choice could be either enzalutamide or abiraterone. People who had received abiraterone prior probably switched on to enzalutamide, and the otherwise. The number of people who had taken taxanes earlier was quite low in this, but nonetheless, there were a few patients who were taken a post-taxane therapy also. So there was a crossover in which the patients who had progressed on the physician's choice could go on to optional Orapalib at progression. So the primary primary endpoint was a median progression-free survival by imaging modality. So, and the secondary endpoints, and there was a hierarchical design to it, that you had to first demonstrate a PFS benefit before you could go ahead and do the other secondary endpoints. So they went on to look for ORR. They then looked for time to pain progression, overall survival, and of course safety and tolerability of olaparib was also documented in this. So like I said, there were 15 genes, of which the cohort A was BRCA1, BRCA2, and ATM. The rest were all under cohort B. So now there was, before we go on to this, there was when we look at the patient characteristics in both the arms were more or less same between olaparib as well as the physician's choice, except that there were more visceral mets and in the physician choice group, as well as there were increased baseline PSA levels that was higher in the physician's choice group. Other than that, rest all were more or less together evenly balanced. So now PROFOUND actually met its primary endpoint. And if we look at the two Kaplan-Meier things, we see that probably the graphs are quite nicely separating. And it had a median PFS as assessed by the imaging of about 7.39 months in olaparib compared to 3.55 in physician's choice arm.
Yeah, good evening, sir.
Pardon? Hello.
So Dr. A.P. Dubey is in Shanti Mukund Hospital, sir.
Pardon?
Hope you are getting, sir. Hello.
Hello, yes.
None, can you mute yourself? Sir, please continue, sir.
Okay. So we got a PFS, when they looked at the PFS, it met its primary endpoint. There was a hazard ratio of 0.34, that is, we had about 66% reduction in the hazard of progression, and the p-value was significant in this case. So if we looked at the subgroup analysis, again, more or less, all of them favored olaparib better than all, whether you had previous taxanes or no previous taxanes. But like I said, the number of patients in previous taxanes were quite low. And then bone only versus visceral only and other metastatic sites, age did not seem to matter. And probably the less number of ECOG2 in this reflects in the longer confidence interval that is visible. However, this study was not powered actually to kind of make the to demonstrate the differences between subgroups. Now, we come to the secondary key endpoints, and the first one was objective response rate. Objective response rate with olaparib was 33% compared to 2.3% with the physician's choice. And median time to brain progression, again, much better with olaparib compared to the physician's choice. When we go on to look at the OS benefit, now here the OS benefit, if you look at it, it's not actually reflected here. One of the major reasons that you can think of it is because probably the patients who were in physician's choice group could cross over into the olaparib group. So if we look at the median OS per se, according to this particular trial, and this thing I think was that maturity of somewhere around 30 to 40% of the data when this interim final OS had come out. And probably because of the crossover, we do not see any median OS benefit, which was statistically significant. You can say there is a trend towards median OS with 19 months versus 14 months. But if you look at the p-value, it is about 0.02. And at the confidence intervals, you look at 0.5 to 0.97. So now we come over for, these are like, I think I do not give much significance to this kind of analysis in which you try and see what would have happened had these patients not crossed over. Now, but yes, you can do that statistically. Most of the times you can play with statistics long enough and you get the results you want. But yes, if you adjust for crossover, then again you see that there is some benefit. There is a benefit, significant benefit in the OS also. Now, if we look at the patients, whether, again, we look at OS benefit, if we look at whether what are the patients who had benefited, you see more or less it is basically there's a benefit with olaparib, which is much better than the physician's choice. But low PSAs, probably it's crossing the line of unity. But again, like this wasn't powered to kind of bring out the differences between the subgroups. Now, this was 50% reduction. This was another PSA 50% reduction in PSA, again greater with olaparib. Circulating tumor cell conversion. Now, this was a thing in which the circulating tumor cells were looked at whether they were more than 5 cells per 7.5 ml of blood. So if you look at whether it was from conversion from more than 5 to less than 5, again it is a little better with better with olaparib compared to physician's choice. So now we look at when we combine both the cohorts with cohort A as well as cohort B. So you find that there is median PFS is 5.82 with olaparib compared with the physician's choice of 3.52. You look that probably the cohort B has dragged down the median PFS when that was seen with cohort A. Probably tells you that the other HRR markers, this probably the olaparib was not as effective. So again, the same subgroup analysis, you put all of them together. So olaparib still does better. And if you look at objective response rate, again, you look at it, it was 33% when group A, and when you add group B to it, cohort B to it, you see that it is dragged down. However, the physician's choice seems to be remaining stable at the same for both of them. Again, this is a median time to pain progression. Again, we see that olaparib is doing better in when we look at it at cohort A. And cohort A, we must remember, looked at BRCA1, BRCA2, and ATM. PSA 50, again, with a complete population, it more or less it says olaparib is better. Now, if we look at median time to pain progression, again, this was with both the cohorts A and B, we find olaparib again better. But if we look at what are the therapies that people shifted onto, you find in physician's choice nearly about 60% of the patients subsequently went on to receive olaparib after they had progressed on the physician's choice. So this was the reason what you can give for why you don't have a significant OS benefit when you are looking at the final results. So again, we are looking at whether we do for BRCA1 cohort A, cohort B. If you look at it, progression of this median investigator assessed radiological PFS, in cohort A, it is about 9.7 versus 3.55, whereas cohort B, it's about 5.59 to 3.35, not much difference there. And again, you can look at the confidence interval nearly reaching up to the unity. So based on this, probably the recommendation would probably be to go for a olaparib in case you only have a BRCA1, BRCA2 and or ATM positivity. As regards the other genes, there doesn't seem to be a very clear-cut benefit that we might be able to get from giving olaparib. So these are the same things, like I said, the treatment switch adjustment. And like I said, if you play along with the statistics long enough, you will probably able to get all these data. If we look at an important thing here was when you looked at them from the genetic point of view of regarding each mutation. What is to be noted that ATM did not seem to have got much benefit out of it. Look at BRCA, CDK12 and ATM. You look at it, the benefit between the ATM was in physician's choice versus olaparib was not much. Compare it to BRCA or CDK12. And as far as the others are concerned, the numbers are really quite low to make any kind of comment. You have 4 patients, 1 patient, and 4 patients, check 2, 7 and 5, and RAD5 54L had 3 and 2 patients on each arm. So probably it's not, and moreover, it wasn't, of course, powered to bring out this kind of differences. But then there is this nagging thought that probably only ATM mutated might not derive as much benefit from olaparib as BRCA2.
Sir, sorry to interrupt, sir. Last minute to conclude, please.
Yeah, I'm going. So, like I said, I'll skip through all these slides because more of them are more or less repeating themselves. Now, coming to the adverse event profile, we find anemia and fatigue to be very high. In fact, if you look at only about all, not just grade 3, grade 4, and if you look at all adverse events, fatigue was the main adverse event which was seen with olaparib compared to the placebo. And then you have anemia, you have nausea, and there were one death attributable to pulmonary thromboembolism. Whether it was due to olaparib is I don't think so, but then that is what the data says. With this, I would like to thank all of you for a patient hearing. Thank you so much.
Thank you, Dr. Deepak, for again a very wonderful talk. Though you had underestimated yourself, I think we are all happy to have a very lucid presentation on the bare facts of olaparib. The trial has been laid bare in front of us, and I think further on, both Dr. Mehta as well as Dr. Deepak have laid the facts in front of us. And now to continue with the discussion in the form of a panel discussion, we have as moderator Dr. A.P. Dubey. He is a senior oncologist at the Shanti Mukund Hospital. He has more than 15 years of experience in oncology, and his areas of interest include not only solid tumors but also leukemias and bone marrow transplant. Prostate cancer is one of his keen areas of interest, and he will be taking us through this panel discussion. And I would like to request him to use the services of Dr. Mehta and Dr. Deepak to answer any questions which are controversial and very problematic. Dr. Dubey, please.
Sir, good evening, sir. Thank you so much for such a kind introduction. And I request Dr. Deepak and Dr. Anurag, sir, to be on board so as to just clarify our doubts on this very interesting panel discussion of genetic testing in prostate cancer. I also request all the panelists, Dr. Shivshankar, Dr. Dipen, and Dr. Prakash sir, and Dr. Puneet sir, and Dr. Gaurav and Dr. Nishant to be on board. I hope all are there.
Yes, sir, we are there.
Yes, sir.
Yes, sir.
Yes, sir, we are.
Everyone is there. And I request, I again request Dr. Deepak and Dr. Anurag sir to be on board, please. So as we all are aware and very clearly been mentioned by...
Sir, we have to do the polling. Can we do it? Just one question.
I guess we can do it afterwards because we are already running.
Sure, sir. Sure. Fine, sir.
So as General B.M. Kapur has very clearly mentioned in his opening address that prostate cancer accounts for lots of mortality and morbidity, and the treatment landscape of prostate cancer is rapidly evolving with the advent of much and more understanding of the molecular pathways which actually drive malignancies. So we are having quite a few therapies which have actually improved the outcomes in prostate cancer, though the optimal sequencing is yet to be evolved. So this is the first question: what is your preferred drug in choice in first-line metastatic castrate-resistant prostate cancer? I would like to correctly forward the question that what are the factors which one consider while deciding the first-line therapy in metastatic CRPC? Dr. Shivshankar.
Good evening, sir. In first-line metastatic castrate-resistant prostate cancer, usually based on the data of multiple studies, they usually prefer if you use a upfront docetaxel compared to hormonal therapy, there is a advantage. But definitely, as you said, we look at various factors like what is the tolerance of patient, what is the clinical status, what is the comorbidity, what is the burden of the disease, all this, what is the age, what is the fitness, PS, and what is the, again, looking at what is the molecular profile. We take all these into account while choosing a treatment option.
Yeah, very correctly said that prior therapies, the response, tolerability, as well as the extent of the disease, the symptoms associated with the disease, all these things are seen before we decide the choice of therapy in the first line metastatic CRPC.
Sir, can I add on, sir?
Yeah, please.
Sir, if the patient have more of a bony symptoms, then we possibly go for a docetaxel or something. If a patient is more of a high volume disease, then again is a candidate for docetaxel. And in a low volume disease, then we can go ahead with abiraterone. And if the patient is not symptomatic, then we can go ahead with the abiraterone.
Yeah, that will be my next question. We are just discussing what are the factors. So you very correctly added one more factor, that yes, the extent and the site of the disease and the rapidity of the progression of the disease, as well as the patient, what symptoms patient is possessing, those are the factors which actually help us to decide between the androgen receptor pathway inhibitors or the chemotherapy. So, like if suppose, Dr. Dipen, that if suppose we decide that because the patient is having very high tumor burden, rapidly progressive disease and symptomatic, and we decide to give chemotherapy. So what drug you will actually...
Yes, sir.
What drug actually you will select for the patient?
Sir, as with the availability of the data, I would like to go ahead with the docetaxel if I choose to have a chemotherapy for the CRPC patient, symptomatic or a high volume disease, sir. So I would go for a docetaxel, sir.
Why not cabazitaxel?
Sir, cabazitaxel, as with the experience as well as the trial data, sir, tolerability issue is much more issue that are problematic with the cabazitaxel, sir.
Yeah, you were right that docetaxel is generally being considered as the first line of therapy, but there's a trial, Fastana trial, where it has been shown that cabazitaxel at 20 milligram per meter square when compared with the docetaxel has shown equivalent outcomes, and it was non-inferior, and also even the toxicity profile was also tolerable. Dr. Shivshankar, you want to add something onto that?
Sir, while choosing the chemotherapy arm, we also look at what are the previous treatment options he has received. Had he received a docetaxel already in an hormone sensitive setting, in that scenario, I will prefer cabazitaxel if the treatment-free interval is less than 1 year. Otherwise, given the patient experience, patient will be definitely much more experienced with a docetaxel than cabazitaxel. And also, if you look at the toxicity, docetaxel definitely is slightly more better tolerable than the cabazitaxel. From these 2 points, I prefer docetaxel. Otherwise, if already patient had received docetaxel recently, that is, in a hormone setting, then I'll go for cabazitaxel.
Fine. Yes. First of all, I would like to say that taxanes are the only drug which have shown the improved survival outcomes as far as chemotherapy is being considered. And the patients whom we are having a high burden disease, where we are considering chemodocetaxel is the first choice, but there is a randomized phase 3 trial, Astana trial, which has shown non-inferiority of cabazitaxel. Also, it is found to be better in patients, elderly patients more than 65 years who have actually received prior RT, because the toxicity of neutropenia is less with cabazitaxel as compared to what is seen with the docetaxel. Puneet sir, I would just like to ask that in what setting you will use these androgen receptor pathway inhibitors or androgen biosynthesis inhibitors in CRPC patients, sir?
Sir, actually, I'm not using it as of now because I'm urologist. I have little experience in this. I'll request someone else to answer on this. I've not much of experience in using this.
Deepak sir. Deepak sir, if...
Yeah, tell me.
Yes, sir. Sir,
Sorry.
what setting you will be much more comfortable to use these androgen receptor pathway inhibitors or androgen biosynthesis inhibitors?
Could you elaborate on the question? In CRPC,
yes,
is it first line that we are talking about?
Yes, sir, first line. First line.
And the question is whether abiraterone first or dosi first, or we are talking about...
whether these newer agent first or chemotherapy first?
I think this point has been well brought out about what is the patient's age, what is his comorbidities. And in a way that I look at it, that sometimes probably giving docetaxel first is a better option because patient doesn't get younger with age. So considering the fact that probably at some time in the future, you might not be able to use docetaxel on this patient. And if he is fit enough, and that is the reason why I have a certain bias towards using docetaxel upfront. But having said that, most of the patients, when you discuss it with them, and this is an important decision, so patients seem to prefer a tablet compared to a injectable. The side effect profile of abiraterone as well as enzalutamide is better than docetaxel. So probably you end up using abiraterone or enzalutamide upfront rather than docetaxel.
So any choice between abiraterone and enzalutamide, what would you select?
I work in a managed care setting, and whichever is available is the one that the patient gets, frankly.
Okay. So fine. So this point is very well been understood that yes, patient with the high burden disease, patient with symptomatic disease, patient with rapidly progressive disease, patient with visceral disease, these patients are the ones which should be considered for chemotherapy. Docetaxel is the first drug which has been chosen by most of us, but yes, cabazitaxel do have the similar efficacy based on the phase 3 data. I would like to ask one by one to each and everyone that castrate-resistant prostate cancer, would you like to continue androgen deprivation therapy? Because here, most of the therapies you'll be adding, systemic therapies you'll be adding, except for enzalutamide, you have to give even steroids to these patients also, which also will lead to the poor quality of life later by bringing the decrease in bone mineral density, that muscle health and all, everything will decline with all these drugs. So would you are we having a very concrete data to continue androgen deprivation therapy even in CRPC patients? One by one, first let Dr. Shivshankar, followed by Dipen, then Deepak sir and Puneet sir.
Sir, if it is not a second generation androgen receptor antagonist like enzalutamide, then I'll continue with androgen deprivation therapy if it is abiraterone.
With the enzalutamide, you will not continue.
With enzalutamide, either I can continue or I may not, looking at the patient profile. But if it is abiraterone, definitely I'll continue.
Okay, Dipen?
Yes, sir. I would like to continue the ADT with both the options, sir, enzalutamide as well as the abiraterone.
Deepak sir?
Yeah, I would continue with ADT with both the drugs.
Okay, Puneet sir?
Sir, the data says it should be continued in all the patients. They still remain receptive to the EDT, so it should be given. It should always be given.
But do we have any concrete data, any randomized trial for continuing ADT in CRPC versus not continuing ADT?
They say receptors still remain sensitive to the ADT, so we should continue even in a resistant stage. That is what the consensus is.
Fine. Nishant and Gaurav, sorry, I just didn't ask anything because everything was going on chemotherapy and all. So would you like continue ADT in patient with CRPC?
Yes, sir. We would like to continue with the ADT in a CRPC patient as advised by the medical oncologist.
Okay. So Nishant, any take?
I would like to concur with the rest, all the panelists. I would also like to continue with the hormonal agents.
Oh, yes. So, yes, though we don't have any concrete data of continuing ADT versus not continuing ADT, but there are certain analyses which have demonstrated an incremental benefit of around 6 months by continuing ADT. And castrate-resistant doesn't mean that the tumor has become independent of androgenic stimulation, because there is still overexpressions of enzymes involved in androgens which are being expressed or which are being found in the tumor cell itself apart from the adrenal and testis. So ADT has to be continued. That is a very common consensus in all the panelists. So what is now the very important question that we have quite a few drugs and few more will come, because we have a quite good understanding of the molecular pathways driving the tumor growth in prostate cancer and driving the androgenic stimulation. So we might have much more newer drug, newer androgen receptor pathway inhibitors. So, but what is the optimal sequencing of these drugs is still has to be evolved. So, like anyone of you would like to take that, how will you sequence the pattern of drugs in metastatic CRPC patients? Deepak sir.
Like I've said, I'd probably go with dosi, followed by abiraterone, maybe put on enzalutamide, re-challenge with docetaxel, maybe later on cabazitaxel. By this time, probably MSI as well as BRCA would come into play.
Deepak sir, my observation, can't we start abiraterone first rather than docetaxel if the patient is asymptomatic?
Actually, speaking, yes, you are right. Technically, abiraterone can be started first. Studies and guidelines agree that they should be started first. But docetaxel is one of the drugs that has been shown to work even on re-challenge. So probably that is the reason why I am a little more biased over using chemotherapy upfront rather than keeping it. But you are absolutely right that abiraterone or enzalutamide, either of them can be started ahead of docetaxel.
Sir, in a low volume disease, shall we go ahead with the abiraterone rather than docetaxel?
Yeah, we should, I guess.
Okay.
Yeah.
So yes, Dr. Puneet and Dr. Deepak has clearly brought the topic that any these androgen receptor pathway inhibitors or androgen biosynthesis inhibitors, they all have data pre or post chemotherapy in castrate-resistant prostate cancer of improving survival outcomes, and any of the drugs can be given depending upon the tumor burden and how the patient is responding. But still, there will be around 1/3 of the patient who will not be responding to these androgen receptor pathway inhibitors. And also, though there are no randomized study, but there are phase 2 studies where it is being seen, there are retrospective studies where it is being seen that giving abiraterone before docetaxel or giving abiraterone before chemotherapy lead to actually decremental benefit, or you can say that it is detrimental based on these studies, but there is no like concrete evidence. But you can see these are the small studies which have even see the overall median overall survival when the docetaxel is being given first and or when the abiraterone is given first followed by docetaxel, that is quite significantly reduced in the patient. Anyhow, but if the sequencing is being seen, so there is a flag study of around 600 patients where it is a retrospective study where the patients were being from the multiple centers were actually retrospectively analyzed, and it was being found that all the sequences are actually improving the survival outcome, but the best survival outcome is by chemo, then newer agents. So the chemo, then androgen receptor pathway inhibitors or androgen biosynthesis inhibitors, this sequence is giving the maximal benefit to the patients. So, and also that, as I said, that patients may 1/3 of the patient will not respond to these drugs, the newer agents, the newer hormonal agents, because of multiple reasons. There's among that one is splice mutant variant. But cabazitaxel still retains the activity in ARV7, means chemotherapy still retains the activity in such patients.
Sir, I would like to bring out one point the clarification on same. Generally, the literature says, even the Davida mentions ki in high volume disease, I would prefer definitely, as rightly pointed out by you, use of taxanes. And why not androgen receptor, these NH hormonal agents? Reason, because second generation AR tend to result into the treatment the resistance in the tumor resistance, and it changes, culminates into small cell etiology. Neuroendocrine differentiation occurs with use of second generation AR at a later stage. So in thinking that and extrapolating that data, I feel that docetaxel definitely has a preference in visceral crisis over enzalutamide and abiraterone.
Yeah, that's a point can be taken. So this is the very important thing which we want to discuss, and I want the help of Dr. Anurag, He has already said that who are the patient whom we need to do the genetic testing. First, I would like to ask Dr. Shiv Shankar, what molecular testing, only you tell that what are the molecular testing you would like to be done in a patient of prostate cancer, or in this case, metastatic castration-resistant prostate cancer?
Definitely, sir. As you said, I mean, like, what is our need? Based on that, we'll choose the molecular profile. If we are looking for a family screening or whether we are looking for a treatment options. In CRPCs, definitely we are looking for a treatment options. Then we will include, since there is though Deepak Munaj sir has clearly brought out that though in the cohort B, the benefit is not very much evident, but guideline says that across all the HRR panel, olaparib is approved. So I'd like to do all the HRR genes in the CRPC setting. And also MSI as an agnostic approach across all the tumors. So I'll also include MSI testing in these patients.
And tumor mutation burden?
It is also again has got an agnostic approach.
Okay. So the molecular testing has to be done, like already Anurag sir has very clearly mentioned that which are the patients, like patient with high risk, very high risk metastatic locoregional or mets to the regional or non-regional lymph nodes, and metastatic castrate sensitive or metastatic castrate resistant. These are the patients, along with intermediate risk patients who are having intrarectal pathology, should be actually tested for the HRR or HRD. So why it is being done? Because at least 1 in 4 patients will have genomic alteration in the genes which are related to double-stranded DNA repair. And there is 1:1 split between the germline and somatic mutations in the genes related to HRR or homologous recombination repair. Means in every 2 patients which we detect to have mutant HRR panel genes or HRD positivity, 1 will be germline and 1 will be somatic. So this was very clearly been mentioned in the preceding trials or preceding talks also, that what is the stage when you are supposed to do. Though Anurag sir has very clearly mentioned these are the early driver mutations, so can be done at any time. But yes, the predictive information they can give us only in the metastatic setting only, because we are using the PARP inhibitor in metastatic setting. So what now? The test result depends upon the site of the biopsy and the sample age and the tumor purity. So it has been seen in the various trials and the various studies that newly collected specimen tend to have higher rates of positivity for this HRR mutant genes rather than the archived samples. You can see that a higher prevalence of HRR gene alteration was found in metastatic tumors, that is 31.8 as compared to 27.2. Though both can be actually tested, but the sample age after 5 years, sample tends to have a lower quality, and thus the success rate might decrease with the time. And these are the bar diagrams which clearly say that the newly collected sample tend to help us detecting more and more positive alterations in HRR panel of genes. And also the metastatic samples might give us more positive rates than the primary sample. That can happen because the selective genetic cloning which can happen between the primary and the metastatic samples. So this, I would like Dr. Anurag to, for the benefit of all the listeners, to tell us that what's the algorithm what we should follow. As far as what my knowledge is, that we should go ahead with we can detect the mutation or the alteration in HRR either by directly detecting it as a germline or somatic or genomic alteration in BRCA1 or BRCA2 or HRR related genes, or by calculating the score, which is genomic scar score or genomic instability score, which is the score of tumor BRCA1 plus tumor BRCA2 plus loss of heterozygosity, telomeric allelic imbalance, and large state scale transitions. So these are the 2 things by which we can do. Yes, the second one, that HRD score, is valid only for the ovarian cancer. So Anurag sir, just I would request just to just repeat those lines, like how to actually we should go, how we should follow the algorithm for detecting these alterations in patients with metastatic C prostate.
Yeah, so I think at the time of a diagnosis, if you have a high risk, very high risk locoregional and metastatic cancer, that is the time when germline testing should be done, at least for BRCA2 and BRCA1. The germline testing should happen at the time of diagnosis. And if germline is positive, then it should be used for as a predictive biomarker if this patient turns out to be the unfortunate one who will have a metastatic disease later. And the germline testing should also be used as a pivot for doing the testing of the kindred of this index case. As far as the somatic testing, somatic or tumor testing is done, tumor testing, as you said earlier, and you showed that cartoon also, can be done at the time of development of metastasis or after the failure of the first line of therapy with the in the metastatic castration-resistant prostate cancer. Once you have that cancer, you can do it. There is the possibility that somatic mutation may fail. It is because sometimes the DNA is extremely fragmented. And if you will see the original the report also, I think they were about 18-19% failure. So in those cases, you can use the liquid biopsy. Liquid biopsy in the PROFOUND study was found to have a sensitivity of 56 or 60%. The 70 or 79 or 78% cases yielded adequate DNA for testing. And of those, then again, 80% were found to have concordance or true positivity. So 56%, but there was another larger study where the concordances were higher. And I think that will also depend upon the platform. But in case you are unable to do somatic testing and your liquid biopsy has also failed, and you have not done germline testing earlier, then you should do germline testing now, because still you will get about 12% of the cases instead of 23% of the cases. You will still get 12% of the cases who will respond to PARP inhibitors. And one more point, that BRCA2 is one gene where there are large genomic rearrangements, or what we call as big indels, and about 10% are big indels. So it will be appropriate that you should do what is known as a multiplex ligation probe amplification assay to look for big indels, at least in BRCA1 and BRCA2, because you can again get some cases who may be benefited by PARP inhibitors. So if there's anything else you want to know, I shall.
So,
sir, Anurag sir, can I ask one small question? What should be the re-biopsy site, sir? It should be the prostate, or it should be lymph node, or a metastatic site?
So bone should be avoided. Rest it could be anything, okay. Because bone, because of the decalcification, the DNA does not. The DNA gets highly fragmented by the acidic decalcification solutions that we use. Apart from that, it can be anything. It can be any site.
Thank you so much, sir. Such a precious piece of advice. If anyone else wants to ask anything to sir, they can ask. So I have learned this, that we should do the somatic testing, and that is negative. We should do the liquid biopsy and the germline testing, and just MLPA has to be done because of the large indels for BRCA2, sir. Right, sir? Anything else, sir?
But I think that's enough from my side. If you have any query, I will be happy to answer.
Okay. So this is. So if asked to tailor a panel for homologous recombinant repair genes testing, which genes would you select for including in the panel? That sir has already actually mentioned that around 15 genes are there which can be actually selected, but as been shown in the PROFOUND trial, that the cohort B actually has not achieved that much benefit as compared to cohort A or the combined cohort A plus B. But still, in prostate cancer, olaparib is actually recommended for all the patients who have actually a genetic alteration in HRR related genes. So this is the profound trial. Already Deepak sir has clearly mentioned about it. So I guess speak, and if any of the panelists want to make final comment, they are please welcome to do so. Dr. Deepak sir and Dr. Puneet sir, if you want to say anything, sir, you can please.
I think you have discussed it very nicely. Thank you so much.
Yes, Dubey sir, you discussed very nicely, sir. It was very detailed discussion, sir. Thank you, sir.
Thank you, sir. Shiv Shankar.
Sir, it was an excellent discussion. Very practical questions were addressed. Good discussion.
Deepen, Gaurav, and Nishant, anything to add on?
Sir, it was thank you, sir, for excellent discussion as well as day-to-day practice helpful.
Thank you. Thank you all my panelists, especially Dr. and Dr. Anurag, whom I have requested, and they were not included in the panel, but even at the last moment, they have actually considered my request and were present on board. Thank you so much.
Thank you.
All my panelists. Thanks a lot.
Thank you. Thank you, Dr. Dubey and all the panelists for that wonderful discussion. I don't think any further concluding remarks are required because he has concluded very well. So now I hand over the session back to the organizers. Thank you.
Yeah, thank you, Suresh. It was a very nice discussion, and I congratulate Dubey and Chaudhary and all the panelists and the speakers for a very wonderful evening. We have learned a lot, and special thanks to Dr. Anurag Mehta for his very lucid talk, and he made it very simple to understand it to everybody. So I thank everybody, and now I will invite Dr. Brigadier H.P. Singh, my friend and my colleague, who is presently the consultant medical oncologist at the Capital Hospital at Jalandhar, to make the concluding remark. Dr. H.P. sir.
Thank you, BN sir. It was a wonderful listening to our youngsters, the way they have discussed a very difficult and a challenging topic. So my compliments to the whole team, to the organizing secretaries, especially BN sir, yourself, and AstraZeneca also. I would only like to conclude that today we have multiple options to manage such cases. Besides the old ones, which are now well established, including docetaxel, cabazitaxel, enzalutamide, and abiraterone. Enzalutamide is slightly superior than abiraterone in the sense that in terms of coronary events, as is also degarelix compared to other anti-androgens. Thirdly, I would like to add is the role of BRC PARP inhibitors. It's come up very well in the PROFOUND 3 trial, which clearly shows that it has got a better overall survival in case a patient has got either germline or somatic mutations in the HRRM genes or BRCA1 and 2 oblique ATM genes. We can certainly use either olaparib or rupacarib there. And lastly, PD-L1 inhibitors are always there, including the tumor mutation burdens. So you have multiple options to offer to your patients. And let's hope that next time we have discussions, we'll get a better clarity of thought in our processes, how to sequentially use them. My good wishes to the organizing secretary and to all the participants for the wonderful talk. Thank you so much.
So thank you all for being here today evening and joining this webinar. Good night, everyone. Stay safe. Thank you all.